attending this meeting. We're going to start with the apology.
5 James.
Okay. Any others? No. Excellent. Minutes of the previous meeting. Everyone happy with those? Excellent. Declarations of interest.
Ken, I'm not sure if it counts. Every time we talk about health, if we ever touch on the Royal Parks or anything like that, I am a volunteer for the community first responders, so that could almost be a standard declaration of interest if it should come up at any point.
Oh, that's wonderful. Thank you, Jim. In that case, we move on to public questions. Do we
No
have
questions, Chair.
None. Member questions.
No questions, Chair.
In that case, we can very quickly get on to the first item, which is the Health Watch update. Jim, are you taking that?
No, I'm not. Nick Derman, who's here with us, will take that. I'm just here to lend support, I think, today.
It's Nick. Sorry, I hadn't noticed you turned up. Good evening, Nick.
Good evening.
Over to you.
I'll turn my camera on and say good evening, then I'll turn it off as I have to lean forward into my laptop, so you don't really want to see up my nose, so forgive me. So I don't have a presentation because you've had the reports, but I'll just run through some highlights if that's okay with you, Chair.
Please, thank you.
Yeah. So we sent over the Insight into Action report, which is something we've been doing since the start of the pandemic, just to give a flavour of what we're hearing and what we're doing. And hopefully you've all had an opportunity to read it. So at the beginning of the report, we give a sort of flavour of the information and advice resources that we're putting out. And this can be on our website and through social media, Facebook pages, Twitter, Instagram, because of course we can't engage in the way that we normally did, other than that with those groups that we have the opportunity to do it via Zoom. So as you can see, we tend to respond as quickly as we can to the things we're seeing and hearing, what the residents are searching for, the information they're trying to find. And we've talked about it before, you know, there have been issues about them finding the information they want quickly and that's easily understandable. So we've done a range of things. I'm not going to read through them all, you know, helping with anxiety when returning to school. So that was after we're talking now back in September, but we've updated that advice based on other information we have. Information's about dentists again. We regularly update that as the situation changes, but it's better, but it's still not great. Carers, we were hearing about issues with carers, the fact that there were new carers, there were existing carers who were caring for more hours because some of the services were reduced. So we created information and resources around that, and actually from that I can touch on it a bit in a minute. We instigated a survey to hear about their experiences during COVID. We heard from deaf people about the difficulty of getting information that was understandable to them. We've done lots around the COVID vaccines. And we've been asked lots of questions about, particularly lately, about the vaccine. So we've created things about the vaccine rollout. So that gives you a flavour of the type of information we've been trying to provide. You've seen some of these reports. We've produced reports on people's experiences of services and information. These have all been published now. Experience of perinatal mental health, and you've got that report for this meeting. We did the review of the GP websites and how easy it was to find information. And on the back of that report, there were 6 recommendations. The CCG said they would implement all 6 recommendations, not only across the websites in Wokingham, but across the websites for the whole of West Berkshire, which was great. And then we produced the report on Wokingham Borough Dentist websites, which unfortunately we had a response from the LDC saying, from the secretary saying, because the way they're set up, they can't impose or ask those dentists to make those changes to the websites. And I know at one point you did invite somebody, whether it's from the LDC, I can't remember, but you invited a dental organisation to come, and I don't think they came. So, I mean, I would encourage you to ask them to come again and explain what the current situation is. And then we talked about the types of issues that we've been seeing. So the continued problems finding NHS dentists, the ongoing issues for residents finding clear, timely information, but I'd have to say that that's improved lately. Access to phlebotomy, that's improved too. Access to COVID testing, and that's improved too. I think the other thing to mention on that first page is the 3 health watchers across the West have been working on the joint healthcare and wellbeing strategy 10-year plan. And as part of that, we were all part of the task and finish group. And as part of that, each health watch across the West agreed to do some focus groups with perhaps hard to reach people or hard to reach groups. And in Wokingham, we did a focus group with carers, adult carers and young carers, and we did a focus group with the learning disability adult group and fed that into the plan. The survey now for that's finished across the West. And we had a meeting the other day and they were looking at the initial results for the initial analysis they did, but it wouldn't come as any surprise. They came up with the top 4 or 5. I can't remember all 5 off the top of my head, but one of them was adult mental health. One of them was children's mental health. Another one was around health inequalities. Just to touch on how we're communicating with people. So where we can, we have digital meetings with groups. A lot of our work is around website and Facebook and Twitter. But I can say in almost each one of those categories, the numbers have increased hugely as people are trying to find information. So I can just give you a flavour here because I think it was asked at a previous meeting. So if we talk about Facebook in Q4 last year, so I'm talking 1920, we reached 1,800 people, Q1, 16,000 people, Q2, 15,000 people. Twitter, Q4, a previous Q4, 4,500 in Q1, 12,000 in Q2, 13,000. So I'm not going to read them all out, but it's just to give you an idea of how we're communicating with people. And then we went to talk about some of the issues we've been hearing about. So we talked about dentists and what we've done about that, but it's a national problem. And NHS England have created a report based on all the feedback they've got from the local health watch, and they're talking to the NHS nationally. We mentioned carers there. So we decided to do a survey of carers about their experience of caring during COVID. We put out a survey that ran till the end of February. We got nearly 100 responses. So we're analysing that. We also ran 3 focus groups with carers, one of which were young carers. So as soon as that's finished, you'll get a copy of that. And then we went on to mention some of the other things we're hearing about. Deaf and hard of hearing, as I mentioned earlier, we created resources for that. And phlebotomy services, I've already mentioned that. So that's just a summary. So I hope that gives you a flavour. I guess I'd say any questions.
Okay, it's open. To speak. Just raise your hand. Rachel, you're first. Oh,
Super. Thank you very much. Just a couple of questions. The first is, I'm sorry to hear that the dentists organisation didn't pick up the idea of making the changes that you suggested to the website. I'm just wondering, is that something that could be circulated to us as counsellors, and then those of us who are able could maybe get in touch with our local dentist surgeries and make that a suggestion on behalf of our residents? That was the first question.
So yes to that, I can circulate that. Will do. Yeah.
Fantastic. Thank you very much. And the second question was the report that you did about helping with anxiety when returning to school. I'm just wondering what the council might have done in order to get that into the hands of schools and parents in the area.
I don't know the answer to that. Certainly it was put out, there was an article on our website, and what we tend to do, an article on the website, we put it on social media, so you'll have a strap line, it points it then to the website where you get the larger article, because of course with social media it's harder to put the larger article, but certainly the council are linked into our social media. But I can ask the question. Yeah,
it'd be really good, because it sounds like a good piece of work has been done. And if we can proactively as a council push that out to schools and parents, that would be brilliant. Thank you very much.
I know one extra thing for that. It was interesting. It's not a criticism. It's just an observation. We try and put these things together as quickly as we can, and we link to national resources that are already there. But we were looking for a video of a young person talking about their anxiety about going and having COVID tests. And the only one we could find was from, I think it was Cumbria County Council. So it was a young girl talking on camera, which was interesting. And the question Joe and I had was, wouldn't it be great if we could have had a local video around that?
Okay, thank you for that.
Super, thank you very much.
Adrian, would you like to speak next?
Thank you very much, Mr. Chairman. Yeah, there's a few things I'd like to say. Firstly, thanks a lot for all the work Healthwatch does. And, looking at those results in terms of responses on Twitter and Facebook, that's a fantastic communication technology for you guys. And, we really appreciate the support and information we get from you. In terms of questions, one of the points that you made in a previous meeting was that the GP surgeries in Woking, I guess that includes Woos Hill, were in, I think, if I remember correctly, you said something like in the bottom quartile of Woking Borough, something like that, but basically near the bottom. Is that still the case? Are the GP surgeries local to Woking still from your side not coming out well in surveys?
So that was from the most recent patient survey results. And when I had this discussion with the CCG and they presented them, there were a number that were in the lower quarter. But what was interesting, that right at the very top was Wargrave surgery, right at the very top in most categories. And my question to the CCG is, what's the learning from this? And I never really had a response to that. So one of our recommendations was, and they accepted that as part of the GP surgery website mystery shop, is why aren't the patient survey results presented on the GP website? Because there's no obligation to do that, unlike they have an obligation to put up the CQC report. And they agreed that that recommendation would be implemented, so at least surgery patients could see the patient survey results on the website.
Is that information up on those websites now or not?
The project's still ongoing.
I mean, I guess, next time we see the CCG rather, we need to ask them some questions around the local Woking GP surgeries. We always get from residents especially in evidence that Woos Hill surgery is difficult to get an appointment, etc. So, you know, I will want to be definitely asking those kind of questions to those guys.
Would you like me to circulate the patient survey results to this group?
I would love that. Yeah, if you could forward on, you know, any pertinent information that you can see. I mean, you know, to be honest, I think we discussed this before in previous meetings, but, you know, my view would be, as part of this committee, that we should align our objectives, and our objectives are, I think, the same as, or very, very similar to Health Watch, in that, you know, what is the health provision for our residents? So which brings me on to my final question, which is really, you know, in the report, I've just had a refresher look at it. I'm not going to criticize it. I know you guys are busy and doing lots of things, but I would like to see a kind of prioritization list. You know, I think we spoke about this before, you know, an action plan of items to be covered. And then, you know, if you're producing this regularly in your report, then this helps us with our questioning back to the bodies like the CCG and the service they're delivering, or I would say purchasing on behalf of our residents. So I would like to see somewhere that kind of action plan. You know, what are the things that need to be fixed? What are we going to be doing next? What needs to be done next? Not necessarily who owns it, but, you know, how do we drive the performance?
Yeah, if it's all right with you, Adrian, I'll email you, and perhaps you could lay that out for me, and I can take it to the board.
Sure. I mean, I would be happy to, you know, attend a meeting with Health Watch and have a discussion with you guys. If you want to do that as a offline activity, that would be great.
Yeah, Jim, do you want to comment?
Yeah, only to say we would welcome that. I mean, we'd welcome you attending a board meeting for that matter. But just having, you know, I mean, it's only fair I come to yours, you should come to mine. But really, having a conversation as soon as you like really helps us. And, you know, we want to make the work that we do obviously relevant to everybody, but also, you know, in the form, as you say, in prioritization that the HOSC would recognize as well. And then we can, you know, feed you more information which will enable you to ask questions of the major partners and suppliers.
I mean, this is, I think we're in such a good alignment here, because, you know, you can see from how many interactions you're getting on your Facebook and your Twitter accounts that you're getting the information that I don't have to hand, frankly. And, you know, that can, I think that can help us all hopefully drive best behavior, good behavior, as it were.
Okay, I mean, if Nick circulates that, let's set up just a video call with amongst ourselves, with both Nick and Joe and myself and anyone else, and we can just have a general discussion and take it on from there. Yeah, but not just a discussion. We will actually do something about it as well. So
yes, you know, kind of. Sorry, I do reporting of these kind of things for a job, and we're always looking for, we've done the stuff we've done, but what do we need to fix now, and what's ahead of us, and what are the priorities?
Sure.
Yeah, absolutely. Thank you very much. I look forward to that meeting.
Yeah, well, you're pushing on an open door. Thanks.
Thank you.
Thank you. Caroline, you're next.
Hello. Good evening. It's probably only going to be a quick one. I read the bit on the pregnancies and mothers and mental health. In the bit, you've identified some key areas that could benefit from investments. I wondered if you consider multiple births in that section as well, because I've tried reading through. Or are they included in the main body there?
So I'm not ducking the question.
No, you can email me the answer.
No.
Just, I was wondering. because multiple births can have severe stress to the family and the mother's mental health, but it hadn't been separated. And I just wondered if you meant them to be all included in that first line of traumatic birth health issues and things like that.
No, absolutely. So very quickly, my colleague Joe, who works part-time for us, but in another role, works for the NCT, did that project, and by nature of it, I wasn't involved because she would ask, and they would say, actually, we don't want your colleague there because he's male, which is totally fine. So I know the project in general, but I couldn't give you that detail. But I'm quite happy, as long as the question's minuted, to get Joe to get back to you and give you the answer.
Yeah, that'd be fine. Thank you very much. Sorry about that.
No, that's fine.
Thank you.
Thank you, Caroline. Jim, Fruin, Councillor Fruin, please.
Thank you. Firstly, thanks very much for these reports. I've just got to express another interest. My daughter's a midwife at the Royal Berks, so I should have said that at the start. They're the standard ones. Very interested to see, especially as I've recently completed a mental health first aid training with a number of other people from the council, the focus on mental health across all of this. I just wondered how that research is chosen, because there's a couple of points in here that I think would benefit from additional research. And if I start with my declared interest in midwifery, the pressure that the teams across all of the NHS, including the midwives, have been under during COVID and over the last year. Is there any research on the workers, the NHS workers, going on and their mental health and how it's affected them? As I say, my other interest is community first responders. So I've seen some of the potential issues with frontline staff on the A&E groups and on the ambulance crews. And I haven't actually spoken to my daughter, but I'm sure if I spoke to her, I'd get some views back from maternity as well. So is there any research looking into that side of it likely to happen? And might appear a strange one, but also the mental health impacts of the scale of development in Wokingham at this moment in time. I've had residents now over the last 2 or 3 weeks who have just been told that now they've had their vaccination and we're coming out of lockdown. In a few weeks' time, they're going to have some return to normality, but they're actually surrounded by now newly started building sites where every day it's the large machinery in and out, people parking 8-wheeled lorries outside of their houses at just before 7 in the morning, waiting to get into the building site. And I've seen a number of cases of now where I believe it's affecting residents' mental health as well. Is there any research going into those 2 areas?
Well, undoubtedly, nationally, there's lots of research going on because I've read about that. In terms of Health Watch, we've come to the end of the financial year. We're in the process of setting our priorities going forward, and that's driven by what we hear from the local population. But as I mentioned earlier, the Joint Health and Wellbeing Strategy across the West has already identified, although it's not published yet, they're going through the analysis stage. It's clear that adult mental health is one part of that as a top priority. So, those are going to be the inputs into the work that goes on in future. But just touching on the mental health, I meant to mention earlier on, it was interesting when we were talking to the carers groups, focus groups, as part of that Joint Health and Wellbeing Strategy 10-year plan. It was fascinating, actually. We were talking to a group of carers and they said, actually, we're quite used to living like this, watching people go about their normal lives. They choose to go out for a coffee at 10 o'clock. They choose to go shopping at 1 o'clock. we've got used to not being able to do that. So to see everyone come into lockdown, it was like, welcome to my world. That was their comment. Welcome to my world. Now you know how I feel like, which was fascinating. What made it more difficult for them, they said, was the period where the lockdown ended and everybody was going out and doing what they did again, you know, and they're looking out the windows going, you're going for your coffee at 10 o'clock, you're popping off for shopping. So I think there's lots of interesting stuff to come out of that report around their experiences over the last year and what could have made things better for them. So I'm not sure I've answered your question, Jim. I think there's lots of inputs.
If you do find any research into those two specific areas, the NHS staff and the impacts of changes to communities through things like development, I'd be interested to see some of that research.
Yeah, okay, I've noted that, Jim.
Thanks very much indeed. Thanks, Ken.
Thanks, Lynn. That seems to be most of the questions, but Nick, can I ask, or I suppose comment and get your feeling for it? I mean, we've never had a lockdown like this in our past, so it's very difficult to measure whether what's happening is good or bad. Is this being handled well or is it being handled badly? And I don't know. I mean, you've been exposed to this now for quite a while, well before we had COVID. Do you have a gut feeling as to whether things have actually gone well or whether it looks like it was all falling apart during COVID lockdown?
Do you mean locally?
Locally, yes.
Well, I guess I have to be careful what I say. I guess I can only... I wouldn't know. I haven't been through a pandemic before.
That's the problem,
but yeah. I guess my comment would be is I meet regularly with my Health Watch partners in Reading and West Berkshire. Yeah. So I'll use their comments rather than my own personal view on it.
That's fine.
And what I did do was share regularly with them Wokingham Borough Council's SITREP report, their weekly situation report. And I shared that with them once and they said, we don't get any of this amount of information from our local councils. So I would share that with them regularly. So I guess that would be my reflection on it.
Okay.
Without digging a hole. Now, it's, I think the consensus certainly was that Wokingham Borough Council has handled it really well. I know from a webinar I went on that some areas of the country almost relied on the voluntary and community sector in the early weeks to get a response up and running because their councils were slower to react. That's certainly not true with Wokingham Borough Council. They were up and running extremely quickly with their one front door policy.
Yeah.
If you look back at the COVID survey that we did, people's experience of COVID, there were several appendixes there about what worked well, what didn't work well. On the what didn't work well, and this was all services, NHS and local council, I don't think there was one negative comment for the council about what didn't work well, and there were numerous comments about what did work well. I'm sure, just like Health Watch could have done better, and we'll all review it, we could all have done things better, but on the whole, I think in comparison, I can only compare it to those webinars I've been on and my colleagues. The response has been better than other places, let's put it that way.
Well, that's always good to hear. I suppose, yeah, this came as a shock to everyone, didn't it? But again, without having a previous understanding of how it went, because we never had one previously, it's very difficult to measure, isn't it? Look, Nick, thank you very. Oh, hang on. With Jim, did you want to ask another question? Your hand's up.
It wasn't so much another question, Ken. It's just some anecdotal stuff from the communities that I talk to with my voluntary roles, and the feedback from care homes, and from the ambulance service, and from the maternity group that I talk to. Have all said exactly what's just been said there, that Wokingham got a lot of things right. And I've actually written to both the leader and to the to Susan Parsonage, expressing that as well. So.
You're on mute, Ken.
I did it again. Thank you very much, Nick, for that. That was a very interesting one, and it was a very interesting subject as well. So, as usual, you've done very well, and we're very grateful for what Healthwatch does give us. I'm now going to move on then to the next item, and that's item 51, the update on change in children adolescent mental health service. Who's doing that one? There she is.
Hi. Good evening, everybody. My name is Louise Noble. I am substantively and usually the head of CAMS at Berkshire Healthcare, head of CAMS and Berkshire Eating Disorder Service. But at the moment, I've stepped aside and I'm focused on a piece of work around transforming the way that we deliver our Tier 4 CAMS service in Berkshire, which is the sort of very acute inpatient service that we provide. And also some developments collaboratively with the CCG and our system partners, including colleagues from Woking and Borough Council on CAMS crisis services, the way we deliver crisis service. So I've come this evening to talk to you about the Tier 4, the inpatient service. And you've all had a paper on that in your packs. If you're happy, I will just share a brief presentation to just sort of talk through the key points of that paper with you, if that's okay.
Yes, please. I'd like that. Thank you.
Thank you. Just bear with me. Okay, so can I just check that you're able to see that slide?
Yep. Can see it.
Fabulous. Thank you. Just bear with me while I make sure that I've got the right view for you. Can you see the main slide and the next slide in the background, or just the main slide?
Just the main slide.
Fabulous. Thank you. I'm taking me a while to get used to the technology. Okay, so just a little bit of background on this. So Willow House is our 9-bedded inpatient service for children and young people. So it works with young people under the age of 18 and over the age of 12. And it's based at Wokingham Hospital, so it's within your patch. And it's been an inpatient service since August 2015. It's commissioned by NHS England. NHS England are currently responsible for commissioning all of CAMS kind of Tier 4 services across the country. And the unit that we have at Willow House, the building is, as some of you will know, a relatively old building. And it was set up as an inpatient unit on the basis that it had a limited shelf life because we can't adapt or develop the internal layout of the building or change it in a way that would enable us to meet the requirements of a modern CAMS service. And so we've been working with NHS England since it was initially set up in 2015 on a transformation plan to create a new unit. And we had capital funding and a service specification that had been agreed to enable us to develop a new unit. And we had our plans in place and the contract is ready to go. However, NHS England have been doing a couple of pieces of work over the last couple of years. One of those is that they've been undertaking a re-review of their accelerated bed programme nationally, but also particularly for the South East region. And also they've had a national programme called the New Care Models programme. And both of those have really determined that we could meet the needs of our local population in Berkshire better through alternative models of provision and through increased use of CAMS general adolescent beds and units elsewhere in the South East region. And so rather than investing in building a new unit, NHS England have asked us to work up a new model to deliver a hospital at home service rather than an inpatient service. And the hospital at home service is based on evidence from research and from models that are demonstrating success elsewhere in the country. So, for example, South London and the Maudsley, who are world leaders really on research into this type of intensive community model, their most recent research and the most recent evidence-based review has shown that intensive community services are as at least as effective as inpatient care in supporting young people who need this level of intensity. And for some groups of young people, actually, they're much more effective. And elsewhere in the country, there's been really, really good success and really, really good patient experience and positive feedback. So we've been looking at some of the London units at Lincolnshire, at Hertfordshire, Dorset, excuse me, up in the North Country, Manchester and New. And so we're working with NHS England and also with Oxford Health, who will become commissioners under the New Care Models programme from April. We've developed a new out-of-hospital service and will be transitioning from inpatient provision to that out-of-hospital service from the end of April. We're starting to implement and test out some elements of the new model now. So what does that mean for the children and young people that we support in Berkshire? Well, at the moment, about 50% of our young people who need that level of care go to units other than Willow House. Willow is what we call a general adolescent unit. There are a number of different types of CAMS units. There are specialist eating disorders units, psychiatric intensive care units, and a range of units that offer different levels of secure accommodation. We don't currently provide any of those. And so our new service has been designed not only to support young people who currently would be supported at Willow, but it's also been designed to support young people who need an eating disorders bed. So rather than supporting the 50% of young people that we currently support, we will, with our new service, be able to provide care for between 70 and 85% of the young people from Berkshire who need Tier 4 level care. Rather than being able to support 9 young people at any one point in time, which is what we can currently do through Willow, we'll have capacity in the new service to support 16 young people at any one point in time. And the new model is also more easily scalable than a traditional inpatient unit. We will obviously still have young people who need an inpatient response. And we acknowledge that that it's important that we're able to access that inpatient care for those young people. So most of those will go to units within our provider collaborative. We're part of a collaborative that spans the Thames Valley, which takes into account Berkshire, Buckinghamshire, Oxfordshire, Swindon, Wiltshire and Baines. And we have 3 units that are relatively close to us who we already work quite closely with. We have the Huntercombe unit in Maidenhead, which is a private provider, but commissioned to provide NHS care. And we are working very closely with Huntercombe in order to be able to develop relationships and pathways to support our young people more effectively if they need to go there. But also the Highfield in Oxford, who we work very closely with, and then Marlborough House in Swindon, which for those young people on the far west of our county may well be a more appropriate setting. And we will continue to organise daycare and to undertake a formal role of access assessment to enable referrals to be put forward and accepted to those units where needed. But we will work more closely with the inpatient clinical teams than we have done in the past, with the aim of then being able to step young people who have needed inpatient care back down into a community package so that they can be back at home and within their local community as quickly as possible, because we know that they do better in their home environment. And as now, some young people may still have to go to units that are out of area, meaning that families have to travel. And that's not the ideal situation at all, and we're trying to minimise that. At the moment, most young people who have to go out of area are needing specialist eating disorders care, and that's why we've designed our new service to be able to support those young people, so it will reduce the numbers that need to go out of area. So how will the new service work? It will in a lot of ways work very similarly to the way that the current service works. So this level of care is the tip of the iceberg, so it's for a very small number of young people, and it is only accessed via community CAMS. So these will be young people who are already within the CAMS service. One of the things that will be different is that we are enhancing the consultation and advice function of the new service. And we are also changing the way that we undertake assessment in the new service, and I'll talk a little bit about that in a minute. The service will continue to run 7 days a week as the inpatient service does, but rather than young people staying overnight at Willow House, they will stay at home and they will come in either for a daycare programme which will run over extended hours, or they will be supported through an intensive package of care that is delivered to that young person in the home, or actually for the majority of young people, probably a combination of the two. Alongside the changes in the community in our Tier 4 service, we've been working very closely with the Berkshire West Clinical Commissioning Group and with colleagues from the three local authorities across Berkshire West, colleagues from the voluntary sector, parents and carers representatives, on targets in the NHS long-term plan to improve crisis support for children and young people. So the picture that you can see at the moment is a graphic that we've designed to show the crisis kind of response model that we are seeking to develop. Alongside our Tier 4 service, the NHS long-term plan requires us and the clinical commissioning groups to improve and enhance crisis services for children and young people so that they are more widely and more easily available across the full 24 hours a day, 365 days a year, and also that we have the ability to provide a crisis home treatment support service as well. We have that service in place for adults, but we don't currently have it in place for children. One of the primary routes of referral into the CAMHS Tier 4 service is for young people who are not known to CAMHS services and who present to us in crisis. And so it's really, really valuable that we're developing these two different services with quite significant investment at the same time, because we'll be able to ensure that they're developed in a joined up way. And both of them, for both of them, our aspiration is to work in a very different and much more integrated way with our colleagues in local authority, in social care and education, and in the voluntary sector. So again, the fact that we're doing both at the same time is going to be invaluable. And kind of just pulling up on that, we are building a new protocol around assessment for young people, both with the crisis service and also into our Tier 4 care service, which will be much more multi-agency than currently. So children and young people who present with this level of need often have very complex systemic challenges and live within a system that can either help or hinder their care and their recovery. And we know that an NHS only response is not likely to enable and support long-term recovery and wellness. So we already work in a multidisciplinary way, but we're very keen to build on and expand and develop that. And there's been, again, some very, very interesting work done with great outcomes in some of the London trusts that have brought together the care plan approach that we currently use with the care education and treatment review process that's being implemented for young people with autism, learning disability and behaviour challenges and other special educational needs and disabilities. And then the other element of this service is the need to work in a very different way with parents and carers, and so bringing in adult services and the other support services that our parents and carers might need while they're working with these really complex, their children through these really complex episodes of mental health. So how does this fit with what our service users tell us? We work very closely in CAMHS with our service users. So we have a cohort of young people and families who are actively engaged in working with us on a range of activities, really spanning from recruitment to looking at the way that our buildings are laid out and how they're decorated, to service redesign and development. We regularly have participation and engagement events with groups of young people and with groups of parents and carers. And so we've spoken to lots of them. We've pulled together the feedback they've given us over the last sort of 18 months or so around their experiences of crisis care and their experiences of Tier 4 CAMHS care. We've also looked at what feedback has come through nationally on what young people are saying about what they want out of crisis care and CAMHS inpatient care and where it's good and where it needs to change and develop. And our new service model has been developed very much in line with what they're telling us. which is that they don't really want to be admitted to an inpatient setting. They particularly don't want to be admitted to an inpatient setting that's geographically distant from where they live. That CAMHS units, unless they're really well designed, often feel like old buildings that are not really kind of fit for purpose. And what they want is they want us to deliver these services in the community. They want us to be able to support them in their home. They want access to the level of expertise and the intensity and frequency of support they'd get from an inpatient setting, but again, in their home. They want to be able to access support out of hours in the evenings and at weekends. They want the education component as well, and that's something that's really important to highlight to you. We have a school in our Willow House in our CAMHS unit, which is part of the Wokingham series of schools. And that is an absolutely integral part of the service and continues to be an absolutely integral part of the service as we move into this new model. And we've been working very closely with colleagues in the Borough Council to ensure that that school provision is retained and to look at how it might need to change. And it will be about developing and growing and enhancing it actually as we move forward rather than anything else. And again, service users and colleagues have been very clear in their feedback that the education is absolutely invaluable. So just to sort of summarise and finish, we have growing numbers of young people with high acuity and complexity in relation to their mental health need. We've seen particular challenges through the pandemic. And one area that we've seen really significant difficulties and growth has been in eating disorders and disordered eating. And with that group of young people particularly, we've seen young people become very, very, very unwell very, very quickly. And that's resulted in more and more young people presenting to us at that level of kind of intensive need. We know that inpatient care is often not the answer, and that for some young people, actually, they get worse when we take them into inpatient settings. So we need to be able to work very differently. And we're very excited about this new direction and the opportunity for us to kind of work more effectively together with our system partners to really transform care for children, young people and their families. So bear with me and I will come back to you. Stop sharing my screen and come back to you. And any questions or constructive feedback, I'd be really grateful.
First person wait to speak is Bray.
Oops. Thank you. I'm not a member of HOSC. I'm actually from the Children's Services Overview and Scrutiny. So
okay.
Particularly interested. I've actually got 3 questions if you don't mind.
No, not at all.
The first one is about what about those children where home is the problem, so they can't be at home? What do you do with them? The second one is, could you describe a little bit more about how the out of hours stuff works? Because I know that on the adult side, people complain quite a lot about not being able to get through on the phone, not being able to get a response, that kind of thing. How it will work. And the last thing, which I'm afraid is kind of my ignorance, but I think I'd like to understand it, is at what age would children transfer from this into the adult mental health services?
Okay, no, they're all really positive and helpful questions. Thank you. Okay, so let me just make sure I can remember them, go back to the beginning and remember them.
What if they can't go home?
So what if home is the problem? Yes. Okay, so there's a couple of responses to that. So one of them is if they genuinely need an intensive mental health intervention. And remember, this is acute mental health care we're talking about. So you treat it like a young person who is admitted to the Royal Berkshire for a physical health care. This is not the long-term care. If they cannot be supported at home, if the risks are too high or the family issues are too significant, but they are safe to continue to live long term at home, then that would be a reason why we might think that inpatient care for this particular kind of level of care will be needed. If part of the root cause for that young person is home, that's part of their, sorry, that's my dog.
Happens to the best of us.
If I leave her outside, she whines. If I bring her in, she'll bark at something. If part of the difficulty that is creating the mental health challenges for that young person is the home setting, then irrespective of what level of input they need, we need to be working closely with our colleagues in social care. And so one of the conversations that has come up in the discussions that I've been having with local authority colleagues, social care colleagues across all 6 of our local authorities actually, is how would we work with foster carers? And some councils have been talking about their plans to develop specialist foster carers for some of this really complex cohort of children, and been really, really interested in thinking with us about how we could be part of the kind of training and support to those foster carers. There is no reason why a young person who was in care couldn't be supported through this model. It's just that the home would be the foster care home rather than the parental home.
Okay, so thanks. The second one's about how the crisis thing works.
Yeah, so there's 2 elements to that. The first one is that's a piece of work for, in terms of the broad access to crisis services, that's a piece of work that's ongoing. So we have the CAMS crisis service currently operates from 8 in the morning until 10 at night, 7 days a week. And that was extended, those hours were extended at the beginning of COVID because we've seen a really significant increase in, we saw a reduction at the beginning of lockdown and then a really dramatic increase post-lockdown, and as the schools went back, we've seen a similar pattern now. We saw a reduction in January, and we've started to see that same surge as we're coming out of lockdown. So young people can at the moment access CAMS crisis support over those hours directly from CAMS, but outside of those hours, the access is via the adult service. And so within the work, the crisis work we're doing around the NHS long-term plan, we're looking at what are the experiences of young people outside of hours, what are the numbers, because the numbers of young people are relatively low, but our data on their experiences suggests that their experiences are nowhere near the quality that we want them to be. And so how can we develop that? In terms of this very small cohort of young people who will be in our Tier 4 intensive service, they'll have access to a different route. So they'll have access to a sort of specific cohort of staff who are available on call out of hours overnight. Interestingly, the evidence from other services in the country has found that this cohort who are being given intensive support very rarely actually need to access out of hours support because they've got such a level of intensity, because we're potentially with them from 8 in the morning until 8 at night. And so they often cope in the outside of hours.
Okay. Thank you. That's interesting. And the last one is about the age where they transfer. Yes.
Yeah. So at the moment, the CAMS Tier 4 services are commissioned up to the age of 18.
Yeah.
So under our kind of current criteria, really, from the point at which a young person is approaching 17 and a half, we would start to be planning with them and with adult services their transition to adult services. We wouldn't generally expect young people in this type of a service to need that kind of intensive level of to transition into that intensive level of service, because the care is usually only kind of 10 to 12 weeks rather than months in that level of service. The crisis service, again, at the moment that's up to 18, but obviously there are lots of discussions going on around the kind of concept of 0 to 25 and how do we do that well. So again, thinking about the crisis, your access to crisis support question, one of the ways that we could look at that might be, rather than may not be cost effective to have CAMS professionals working 24 hours a day, because the numbers of young people that need to access between the hours of 10 at night and 8 in the morning are very, very low. But if we were to look at a service that spanned up to 21 or 22, for instance, then that might be a different way of doing it. We don't know what that looks like yet. We've still got to do a lot more looking at the data. It needs to be very driven by the data, not just numbers, but the quality and the experience.
Yeah. Okay, thank you very much.
Lovely. I'm going to move straight away on to Caroline Smith now. Thank you. No, can I go to Jim Fruin, please? It looks like you were waiting first.
Thank you, Ken. Louise, I know each case is different. I've had a relative with similar sort of issues that you've mentioned already. One of the benefits is probably the wrong word, but one of the effects of in hospital or in whatever the term I'm looking for is, not at home, is respite for the family and for the carer. So what are you doing to cover that if we're taking that away from them?
Yeah, I guess that that's a really, really, really interesting question, and it's a really difficult balance, isn't it? Because what you're trying to balance is the need of the young person and the impact of inpatient care on that young person's long-term outcomes, which we know is not good. So that's why we're moving away from inpatient care. But we've also got to balance the well-being and the resilience of the family, and not just the family, not just the parents and carers, but also any siblings that we have in the home. And so there's, I guess, three things that we're doing around that. The first one is about the way that we want to work in a much more multi-agency way. So it's less health centric, and that we're working in a much more collaborative way with our system partners, so that we're actually bringing together the care planning around that family. So it's a much more systemic approach. The second thing we're wanting to do is to try and start the conversations and provide this level of support earlier, because what we know at the moment is that because we know that inpatient care is not very effective, and often, particularly for young people who are presenting with emotion regulation difficulties, where there's a lot of self-harm and a lot of kind of suicidality going on, they often get worse in inpatient settings. But we delay. I think we try and hold them for too long in the community because we know they get worse in hospitals. And so what we really want to start to do is try and identify these young people earlier, before the families get so tired and so battered and so low, so that we're able to offer a more intensive level of support at an earlier stage to try and prevent them from getting to that point. And it may well be not just the Tier 4 service that does that, but it might be a combination of the new crisis services and the new crisis home treatment service that we're able to deliver, but also the way that we work collaboratively across different agencies, and kind of developing and extending that. And then the third bit is that the way that we provide treatment is very focused around supporting parents and carers. So that's very different to the way that we currently work. Currently, the young person comes into us. A lot of what we do is focused around the young person. The way that the new model will work, there will be a really, really, really in-depth kind of program of support for the parents and carers. So we're actually teaching them the skills and the strategies that we're teaching their young person and that our clinical staff are using, so that they are developing skills and abilities to be able to support that young person. So again, we kind of recognise that there will be some families for whom it's just not possible and they need that level of inpatient provision, and that will still be available. But with those combination of things, that we really hope that we can keep a lot of young people at home. Lincolnshire is, sorry, I'm very, very loquacious, so I'll try and quieten my answers down. But just to say that Lincolnshire have been running their new model for a year now, and in their first 6 months they were able to reduce their inpatient admissions by 95%. And really very successfully look after those young people at home. And a lot of parents tell us they want to keep their kids at home. So,
and excuse my ignorance on some of these things, but respite would be available through the other services should it be required.
I mean, if respite is appropriate and respite is needed, because CAMHS is not a respite service and has never had that sort of function or ability. So if a young person kind of meets criteria for the respite services that exist, obviously that would still be available. Yeah.
It will come out of this holistic approach.
Yeah.
That's lovely. Thank you very much for this.
We've got Caroline now. Thank you.
Hello. You've
Hi.
actually covered. Hello, good evening. You've actually covered some of the questions I was going to ask. But I was going to ask one about increasing capacity, because you've mentioned what we've got now. Have we factored in enough with COVID and the increase in mental health? And I was reading today that self-harming's on the increase. Have we built in enough?
Yes, we think so. So I mean, it's difficult to predict, isn't it? Because we don't know quite what's going to happen with COVID. So we know that we saw a really, really high upswing in crisis after the first lockdown. Although it's very early days, it doesn't look like it'll be quite so acute after this current period of lockdown, but we're still waiting to see. We will have, at the moment we've got 9 beds and we'll have the capacity for 16. Only about 6 of those beds currently are occupied by Berkshire young people, so we are more than doubling the capacity of our local service. And that there is an increase in the numbers of young people that we'll be able to take from an eating disorders perspective as well. At the moment, we would be able to support, we support about 36 young people through Willow in the course of a year, and the new service will be able to support 64 because there's some increased throughput as well. So again, we're sort of almost doubling the amount of capacity that we'll have. The other thing is that it's very difficult to scale up an inpatient provision because you've got 9 beds and you can't increase the numbers of young people that you admit without building, and that takes years, and that's where we're a little bit stuck across the region. So there is building of new units going on, but they take quite a long time. Whereas with this intensive community model, actually with relatively little investment, we can put more staff in and then support more young people. So it's easier to scale if we see more increase than we've been predicting.
Okay, thank you. Another one I was going to ask, with the emergency crisis, you talk about 24 hours a day. What about bank holidays? Is there like Christmas when there's like a 3-day break?
Yeah, so our service already operates over bank holidays. Yeah, so we already run over bank holidays. And the CAMHS, the Tier 4 service, will run 365 days a year.
And also you mentioned the transition from 17 to 18. You said you only expect them to be for 3 months. What about children who are going to be a lot longer, going into 18? Do you make that a smooth transition working with them?
Yeah, so that comment was about the Tier 4 service. So young people who are in that kind of Tier 4 service will only be in for a short period of time. But our transition protocol at the moment is that we would start working with adult mental health services and that young person 6 months before their 18th birthday. There are relatively small numbers of people who will be experiencing such acute mental health difficulties that they will transition through to an adult service. Transition is a national issue, and it's not as smooth as we would want it to be. I don't think. I think that would be fair to say. Yeah. It's been a quality schedule target. We've done a lot of work on it over the last few years. We've got some quality improvement project work going on, looking at transition in specific elements of our children and young people's services at the moment. So we're kind of constantly striving to improve that transition service. And with the way we're developing both the new crisis service and the Tier 4 service, we're working with adult services to try and make sure that we don't inadvertently create any bumps by not having services that join up.
Yeah, thank you. Thank you. Thank you very much.
Thank you, Caroline. Adrian.
Oh, hi. Thanks very much for taking my question. Couple of questions, really. We have a local site. Obviously, parents who have children in these situations, if they're local to WBC, which I guess they are, they would be able to visit relatively local to WBC. What happens if they get taken to locations which are really off-site and away from WBC? And secondly, what about parents who really struggle to pay for travel costs, train travel, or perhaps don't have a car or don't have the money to go see their adolescent?
Okay, so I guess the situation in terms of families who have to travel is that's already happening. So 50% at Wokingham last year specifically, actually, we had 13 young people from Wokingham who needed admission who needed Tier 4 care. 7 of them were able to be supported at Willow. The other 6 had to go to units elsewhere in our provider collaborative. One of them was a unit that was out of area because Willow's only a general adolescent unit. Okay, so up until now, if you've needed treatment, specialist intensive treatment for an eating disorder, you've had to go somewhere else. There wasn't any choice. And if you needed psychiatric intensive care, or you needed a secure unit or a specialist learning disability or ASD unit, you have to go somewhere else. There isn't any choice. So this new service will be improving that for a significant number of families, because they will be able to be supported either in the unit at Wokingham or in their own home. Okay, so that will make a significant difference. For those families where there is travel and there are challenges around travel, then we have a social worker as part of the unit, and all Tier 4 units do. And so part of their remit is about working with those families to ensure that they know what support they're able to access, and that they are then in receipt of those relevant benefits and support that would enable them to travel.
Thank you very much. And a second question, really. It sounded to me like this is a new creation, this service, and it's sort of being prototyped and built up over time. One of the things, sorry, I'm a very cynical person. One of the things I see very often is there is a bow wave of resourcing near the commissioning of new services and etc. And when the service is up and running, it's that resourcing, that money, that having a social worker always there in the team, all these things start to degrade over time. Are we able to say that the level of resourcing, the level of funding, the level of attention from the different roles that are engaged in these teams, do you expect those to remain similar to what they are with the current examples?
Yeah, I share your cynicism. In terms of the CAMHS Tier 4 side of things, actually in both there are investment plans. So in terms of the CAMHS Tier 4 service, the National New Care Models programme has been running for the last sort of 2 or 3 years, and the kind of bow wave of kind of pump priming intensive investment funding was put into the Vanguard sites, which we're not one of. So they had quite a lot of kind of very early seed investment. We're beyond that, but the New Care Models, what's been proven with the New Care Models programme is that developing these community models save money, because for every one patient who is treated in an inpatient setting, you can treat 100 patients in a normal CAMHS community setting. It's a very expensive way of delivering care. And so the type of community model that we're delivering is a Tier 4 equivalent. It's an inpatient equivalent model, so it's not anywhere near. It's not going to give you those cost savings, but there are cost savings that are accrued. And so this, along with other ways of working differently in the community, are releasing investment from Tier 4 services, which is then being ring-fenced to be reinvested back into community CAM services. So as we're part of the Thames Valley Provider Collaborative, and there's a 5-year finance plan for the Thames Valley Provider Collaborative that includes a growth element and also some expectations around the way that might release some money that we're able to then reinvest back into community services. But the key point is that any money that's released is ring-fenced to be reinvested back into this further type of service. Now, we could get changes in government and they'll change it all, but...
Yeah, well, I sincerely hope it is ring-fenced, but thank you very much for your comprehensive answer, Louise.
Thank you. Michael.
Thank you, Chairman. Oh, hi, Louise. Hi, how are you?
Hi, I'm good, thanks, Michael.
I don't think we've spoken before, so I just really, a bit of a general question, so it might be a bit of an awkward one, but I thought I've got to ask it. I mean, you mentioned during this presentation that you just given that there's various mental health issues, and obviously can be higher than usual because of the lockdown and all that, with lack of contact, really. And obviously self-harm was mentioned as well. I was just really wondering how you were going to make sure that no one falls between the gaps, especially when people have problems trying to get hold of CAMs. I know this has been a bit of an issue when I was actually on the management committee of ARC. It got mentioned on quite a few occasions. So I know there's going to be some, unfortunately, that I think will fall between the gap, but try to get as many as possibly can will be good. And I'm just really wondering how you might respond to that. Thanks.
Okay, so you're asking a question that is outside of the kind of the brief around the Tier 4 service and the crisis service. However, I guess the answer to that is that Berkshire Healthcare CAMs are part of the wider collaborative of services that are commissioned and deliver care for children and young people with emotional wellbeing and mental health problems. So we are only one agency that is part of that provider network. Now, what we've been able to do through COVID is, I think, really grow and enhance the way that we work as different agencies together and how effective we are at collaborating. So I'll give you an example. When we first went into lockdown back in March last year, obviously everybody had to kind of effectively shut down overnight and find different ways of delivering care for children and young people. Now, in Berkshire Healthcare, we were quite fortunate because we're a global digital exemplar, and we've had very good IT access, so we didn't close our doors at all. And we have continued to deliver care and deliver services to the same level. In fact, actually, our activity has been up significantly over the last year than previously. But some of our partners who were delivering, say, for example, youth counselling services or the anxiety and depression clinic that the University of Reading run, which is a low-level anxiety service that we work very closely with, they weren't in quite the same position, and what we identified was that our communication wasn't very good. So we put weekly meetings in place where we actually worked collaboratively together, so that every agency that was involved in delivering part of the kind of emotional wellbeing and mental health pathway knew what the other was doing. We were sharing our resources and our experiences in terms of how do we manage the infection prevention control, how do we manage the estates challenges we're facing, what we're doing around digital, can we share training to equip our clinicians. And we've been able to carry on that closer working. So there's no kind of easy answer to that solution, to that question, because it's multiple different agencies that are providing these services, and the only way to stop kids from falling through the gaps is to make sure that we're actually all working together. And where possible, we've got more joined up commissioning going on. But I would say that through COVID, we've been able to really grow and enhance that, and will continue to do so.
Oh, that's good that you've obviously got to work. I mean, that makes sense as well. I think the one thing is, I won't go on too long here, but I think the one key thing you mentioned was communication and trying to get that message out, whether it's CAMS or whether it's another organisation, is absolutely key to this. So, yeah, it's good that you're collaborative working as well. That I think we're all in this same boat together. So yeah, if some good has come out of it, maybe that is the good that's come out of it.
And from a Wokingham perspective, ARC and colleagues from the early intervention, early help services in Wokingham that Wokingham Borough Council deliver, they've been very much part of those conversations and those meetings, and they're part of the work that is going on more broadly across reviewing and developing emotional wellbeing and mental health services for children and young people.
Yeah, okay. Thank you very much, Louise. Thanks.
We have another one. Rachel, would you like to put your question?
Hi, yes, I just wanted to ask if you could explain a little bit more about how the education will work, because if I understand rightly, you're going to have young people. Some of them are going to be in daycare centres, as it were, and some of them are going to presumably be going to their normal schools. And I was just wondering how we would be able to support them in education.
Yeah, okay, so it's unlikely that young people who need this intensity of care will be actually in their normal school. Mm-hmm. So they tend to be either being supported through Foundry College from a Wokingham perspective, or trying to be engaged by Foundry. So we have a school at Wokingham, at Willow House already. So it's been there for actually since this service used to work in a different way. And in fact, actually, I met with Sally, who's our teacher, who's our lead teacher at the school yesterday. So for those young people who are coming in for daycare, and we anticipate that about half of the kids we're supporting will be coming in for daycare every day, they will continue to attend school at Willow House in the way that they currently do. For those who are at home, then we will, our school, our education provision, Sally, will work closely in the way that she does now, and they have previously done in a more in-depth way, actually, with Foundry College, or they're at the equivalent in whichever local authority the young person comes from, and with the sort of the home school for that child if it's not long term going to be Foundry College, and they do that already. So already there is very close working, close collaboration between the two, where they work together in terms of what are the educational needs of that young person, what's the programme, the best way of supporting them, and they collaborate over who will be delivering what. One of the things that we think we will be able to do better in the way that we're working with the new service is that we'll be able to take some of the learning both within our school and the education setting, and utilise the digital way that we've been working with some of these young people who are at home. And we also think that having our CAMS workers going in to support young people on a daily basis, they will be, one of the things they'll be able to do is then support that young person in some of the educational tasks that they've been set, or in accessing lessons. So Sally will be able to give you that in a more eloquent way. But yeah, it's very much something we're thinking about.
Okay, super, thank you.
Thank you, Rachel. Nicholas, would you like to ask a question?
Yeah, hi Louise.
Hi Nick.
Yeah, the first thing is, I absolutely do know that they engage with their service users through their CAMS participation groups, because Health Watchers did go along to some of those groups before the lockdown and saw very well engaged groups. But my other question was, Louise, was that recently Hunter Combe received a CQC inspection that rated it as requires improvement.
Yeah.
And I just wondered if you're involved in the discussions and.
Yeah, we are. I'm not personally involved in the action plan and the work that's going on into Hunter Combe, but I'm in almost daily contact with the clinical director for the Thames Valley provider Tier 4 provider collaborative and NHS England, because it's really important for us that that service is supported to put in place the improvements that are needed. And we have, I don't think we've got any Wokingham young people in Hunter Combe at the moment, actually, but we have had young people from Berkshire who are there. So I'm being given the level of assurance that I need by the quality leads and the clinical director, and also by NHS England, by their quality team who were involved. The care that our young people who are there at the moment are receiving is safe and of high quality and effective. I know that they have, there's a lot of kind of intensive support going in from across the provider collaborative, and we've been part of conversations around talking about how we might do some joint recruitment, how we might share training, how we might work more collaboratively together. Staffing is a challenge across all CAMHS Tier 4 units. It's probably not news to you. But I'm being given that level of assurance from both NHS England and from our provider collaborative clinical leads and clinical director. And we have also started some meetings ourselves with our colleagues at Huntercombe, because they are our closest unit. So I met with them I met with the operational lead and the director of the service and one of the consultants last week, and that's given me personally an additional level of assurance. And we are now putting in place some shared meetings across our senior clinical staff, so our consultant psychiatrists, our lead psychologists, again, to make sure that we're sharing policies and procedures and looking at how we might do some joint training. So I have a high level of assurance at the moment, Nick.
Yeah, okay, thanks, Louise.
Thank you, Nick. Louise, I think that's about it. Could I just make the comment on the reporting? One of the things that always bugs me a little is when we see a report come out and references are made to, I don't know what you call them, the design work that's been modelled and looked at. And you say, oh, it's wonderful, you know, this is definitely the answer. And then you've got independent reporting as well that is often referred to. Is it possible when you produce these reports to actually include the references?
Sure.
There's some of us that would like to go away and look at that beforehand to see exactly what a lot of this is based around. Otherwise, it's a bit cynical, but we sometimes often think, what's going on behind this, what's triggered this, what's causing it.
Yeah, absolutely.
You're ready to go ahead in one direction and suddenly you've changed direction. Yeah, well, why is that? And if you keep that in mind and always do that, then it gives us something, and we'll probably ask some more trickier questions, but it'll be more fun.
No, that's fine. That's no problem. It's really helpful to have that feedback, because actually I did have references in earlier versions of this report, and then other people asked for them. I had different comments. So it's about knowing your audience, isn't it, and what the information is that you guys need. Okay.
Thank you very much for that. That was a very interesting presentation and a lot of interesting questions as well. I thank you for that, and I'll let you escape now, I think.
Lovely. Thanks very much. Thank you. Bye-bye.
Bye. Right. Now, that was the last item on this meeting. So, in fact, all that's left now is for the meeting to be closed. I just wanted to say this is the last cost meeting for the year. I wanted to, in particular, thank Democratic Services for all their patience with me and for helping the Hoscout and keeping it all together. And in particular, Madeline, thank you very much for the help that you've given in this. And look forward to seeing you all again sometime. Close the meeting. Thank you.
Thanks, Ken.
Thank you.
Madeline.
Bye-bye.
Yes.
Thank
Yeah,
you.
thanks.
Bye-bye.
Thanks,
Thanks,
bye-bye.
everyone. Good night.
Bye.
Good night.
Good night.